Let me tell you the story about the gastric sleeve. In the early 2000s, it was being used in Europe, and it got reported in medical journals. And I read those. The problem is medical journals are not very well peer reviewed. So I'd read this article that said gastric sleeve is a great way for people to lose weight. And the next article is, here's the best way to manage breast cancer. And I'm an oncologist, and I know it's wrong. So I didn't know what to make of that. But on the East Coast, there were a gentleman who was doing this operation, the duodenal switch, and some really big men, 500, 600, 700 pounds. Okay, so they went to surgery. The patients weren't doing well, had trouble keeping their oxygen levels up. I mean, those patients are hard to operate on. And so they decided this, let's do the sleeve, stop. Okay, let them lose some weight and come back. But guess what, they didn't have to come back. They lost all their weight without it. So that was Michel Gagne. I went up and looked at his program in 2005 and started offering it in late 2005. So this is what a sleeve is. It's removal of the storage portion of the stomach. All of this stomach, when it's empty, it just kind of collapses down. It's really thin and flexible. Then expands out to hold the food. That part of the stomach is removed. And what's left is a long muscular tube. That's the sleeve because it looks like a shirt sleeve. That's where it gets its name, with a little pouch at the bottom. You can eat more than if you had a band or a bypass, but a lot less than you can now. So caloric restriction is the way it's working, right? But what's driving the success in the long run is you're taking the cells that make that hunger hormone out of the picture. So hormone levels drop down low, so you're not struggling with hunger. The beauty is you can eat all the food that you could before. I didn't say it, but with the bypass, sweets, Sweets are gonna give you dumping syndrome, okay? Alcohol you have to be really careful about. Some fatty foods you have to be careful about. Not so with the sleeve. I'm not saying you have poor dietary habits after a sleeve, but what I'm saying is you're not intolerant to anything that you weren't intolerant to before. So it reduces the capacity, reduces appetite, really good long-term results, and it's rapidly replacing the other operations because it's simple. That's why. So the surgeons that were doing bands learned how to do sleeves, and it works better. I don't have to have all the phone calls of my band needs to be adjusted and come in, and I mean, that's just really is difficult to manage. This is how the sleeve is done. This is when it's done laparoscopically. This is not one of my surgeries. I point this out. This is the sleeve here, which is a little big. I make them a little smaller than that. And this is the part of the stomach that's removed. This staple line here is one of the risks of a sleeve, is that staples could break, could come apart after surgery, and things would leak out from the inside. And so this really needs to be reinforced. I did the first 20 cases in 2006. I had one lady with a leak, and she had it way up high, right where the esophagus turns into the stomach, and she did okay, but then I realized this is a different operation. There's a little more pressure inside here because things are going down the normal way, but there's a muscular valve right here that controls how fast the stomach empties, and it stays closed. And so if it gets full of fluid, there's only one way for it to go, is to come up or for things to perforate. And so what this surgeon has done is put these little clips on here to try to prevent that from happening. I've tried everything with this, and I can tell you what works the best now are some buttressing reinforcement strips that go on these staplers that the staple tips cramp into. And since we started using those, we haven't had any leaks. But leak is one of the risks. And I'm gonna go through the rest of them here in just a second. So here's a lap sleeve. Usually 5 incisions, 5 or 6. Takes 30 minutes most times if you have an experienced surgeon. Stomach is removed through one of those incisions. You gotta get that stomach out, okay? And it doesn't just come out. We have to cut the muscle underneath, stretch it, rip it, tear it, and pull the stomach through, and then put stitches down in that repairs that muscle separation, okay? It hurts. It affects the hospital length of stay. It's harder to get up and around when every time you contract your abdominal muscles, it's hurting where those stitches are. So it increases length of stay, it increases narcotic use. There's a risk of hernia, okay? So you don't want to break those stitches. For 6 weeks, no heavy lifting. 6 weeks. And then there's a 1 to 3% risk of hernia forming later in life because the muscles have been weakened. So activity restrictions, infection related to removing the stomach, staple line leak, we were already talked about, and here's the big one, okay, that doesn't get talked about a lot. It's blood clots in the legs. Anybody who's overweight who has surgery, especially women, have a higher risk of developing blood clots. When you're on the operating room table, you're not moving, the blood's just sitting in the veins, you can develop blood clots. So the tenet is twofold. One is to give a little blood thinner right around surgery, okay, and then be up and active afterwards. The reason why people who take long plane rides get blood clots, like Al Gore did back in the day, is because he's not moving around. The blood's just sitting there, and you get a clot. So anything that hurts, right? Anything that hurts that prevents you from getting up and around increases the risk of blood clots. So a little bit of blood thinner and then be active. Some people put patients, some surgeons in this city, put patients on blood thinner for a period of time, even after they go home, because they've had blood clots. Here's the problem with that. If you happen to get in a car wreck and hit your head, you're not going to stop bleeding. And if you bleed inside your brain, it'll be fatal. So it's not without risk itself, right? So the key, though, is to be up and active, because muscular contraction is the way we get blood out of our legs back up to our heart. Be up and active. So the question is, how do you get that? Because that is the stomach that we remove, okay? How do you get that out without making an incision, okay? And that's the mini sleeve that I'm going to tell you about. It uses the technique I told you called NOTES, Natural Orifice Transendoscopic Surgery. It was first reported in 2006, where somebody went through the stomach to take the appendix out without making cuts. And it's been done for gallbladders. Look at this, transvaginal, going through the wall, back wall of the vagina, right under the cervix into the abdominal cavity. And then in 2010, a colon. I thought, if you can pull a colon out, why can't you take the stomach out? In 2011, I did the first transvaginal sleeve. But the instruments are not really designed for it. The staplers are not really designed for it. And quite candidly, when you talk to women, some of them don't think that's very cool. Right? I don't care. I don't care if I don't hurt as much. You're not going down there, you know. So I go, okay, well, that doesn't work. Let's do it different. Let's go down the mouth. And so I did that in 2012. We now do 200, to 2015, we've done about 200, and it's called the McCarty Mini Sleeve. And so the deal is that you don't have to have that pain.